sensory, motor and secretory. Sensory, motor and secretory. Again in sensory, there are two divisions. General sense, that's mean carrying the pain, touch, temperature, and special sense, the taste. The sensory nerve is usually carried by the lesser palatine nerves and partly by the greater palatine nerves, which ultimately carried to, it is not clear to you, because when I will teach you the parasympathetic ganglion, that you will then know the courses of the nerve or glossopharyngeal nerve, facial nerve, when we will teach you in details. But simply, it is lesser, general sense is carried by the lesser palatine nerve, then in passing through the glossopharyngeal nerve, then to the higher center in the cerebral hemisphere, from the thalamus, then to the cerebral hemisphere. So, the main nerves carrying the general sense, means pain, touch, temperature, is mainly the lesser palatine nerve and partly by the greater palatine and nasopalatine nerves. Finished now for the time being. And the special sense is also carried by the lesser palatine nerve, then to the through the geniculate ganglion, then to the nucleus tractus solitarius of the brain. It will be not easy for you to understand now. Just take it granted now when I will teach you in the nuclei of the cerebral hemisphere of the brain, then it will be clear that what is nucleus tractus solitarius. Right? Nucleus tractus solitarius mainly take the special sense, mainly the taste. There is a nuclei, nerve, cell bodies accumulated to form a mass, elongated mass. We call it nucleus tractus solitarius, situated in the brainstem, in the brain. Again, to sort the general sense and the special sense. General sense is carried by the lesser palatine nerve, greater palatine nerve, and nasopalatine nerve. Special sense mainly taken up by the lesser palatine nerve. Then via the different routes you have to know, through the all muscles of the palate are supplied by the pharyngeal plexus, cranial part of accessory nerve through the vagus, except tensor veli palatini supplied by the mandibular division. Barbar eta ami bolchi. Except tensor veli palatini, which is supplied by the trunk of the mandibular nerve. Trunk of the mandibular nerve gives a branch known as the nerve of the nerve supplying the medial pterygoid muscle. These nerve, mainly this nerve of the pterygoid, nerve to the medial pterygoid is a branch of the mandibular nerve. Mandibular nerve is a branch of the trigeminal nerve, and this nerve to the medial pterygoid mainly supply the medial pterygoid muscle, which move the jaw. But in addition to supplying the medial pterygoid muscle, it also supplies two other muscles, tensor veli palatini and tensor tympani. So this is the exception, and whenever there is an exception, there is a chance of having question in the examination. So you have to know it. Secretomotor, I have already told you in the last class, the palate has got glands, palatine glands, and it is very essential to secrete palatine mucus in the oral cavity. These palatine glands, again, it's supplied by the lesser palatine nerve. So lesser palatine nerve is a mixed nerve carrying secretomotor supply to the palatine glands, also carries the sensory supply. This lesser palatine, it's coming from the from the superior salivatory nucleus, then to the facial nerve, then to the geniculate ganglion, then to the petrosal nerve, greater petrosal nerve, then to the nerve of the pterygoid canal, then it relay in the sphenopalatine or pterygopalatine ganglion. From there, lesser palatine nerve arises, which supply the palatine gland. আমি যেটা বললাম মনে হচ্ছে বাবার এটা মনে কি করে থাকবে, how will you remember? It will be as easy like anything when I will teach the this pterygopalatine ganglion. It is a nothing. The course is very easy. It seems it is very tough to remember all things, but when you I will teach the pterygopalatine ganglion, it will be as easy as like thing. So nerve supply of the palate is very important. Only you have got now a full-fledged idea about the motor supply, all the muscles, and rest, sensory and secretomotor, just you have got now superficial knowledge. Because when I will explain in the next week, then it will be as easy like anything. Just remember, in this way you will write. If we come the nerve of the palate. Next, last part of the palate is, so these are the nerve, these are the nerve, mesopalatine nerve, greater palatine nerve, and lesser palatine nerve. Coming out from the greater palatine canal, coming in the palate by through the lesser palatine foramen to supply the palate. Next. This is the sensation, look, carried by the lesser palatine nerve passing through this greater palatine and also by the lesser palatine nerve. Then it relay in the geniculate ganglion, then it goes to the facial nerve. In this way, I'm just giving the diagram, but the next week when I will teach the, or week after the next week, when I will teach the parasympathetic ganglion, it will be as easy like anything. Next. Next, applied anatomy. There are two applied anatomy regarding the palate. One is the cleft palate, and another is the palatal muscle paralysis or nerve injury. Cleft palate, it will be dealt in detail in your embryology class. Just for sake of, just for 2 to 3 words, our face is derived from 3 processes, mesodermal processes. One here, we call it frontonasal process. A process coming from in this vertical direction, we call it frontonasal process. And 2 here, one upper process called maxillary and lower is the mandibular process. In this way, our here the eye will develop. Here the eye will develop, and in this way, to complete the mandibular process, forms this lower jaw, lower lip, etc. This mandibular process, and this maxillary process grows and hits the frontonasal process and join here. And this frontonasal process again has got a depression and elevation so that it has got lower 3 sub-processes. One median nasal process, nasal means nose, and lateral nasal process. You can easily understand this is the medial nasal process and this is the lateral nasal process, and it is the depression. There is a depression which forms our external nares, right? So, in the midline there is a process, frontonasal process, maxillary process from the side, one on either side, right side and left side, and ultimately these form the upper part of the face including the upper lip. This frontonasal process, it is like that, it gives a horizontal, it gives a horizontal process backwards, right? And this is the maxillary process. This maxillary process also gives a horizontal plate, each going to the midline. When we see through the mouth, what we will see? Now we are viewing through the mouth. So midline, there is an frontonasal process, blue color. And laterally, there are two maxillary process joining the frontonasal process. তাই তো আমরা ভেতর থেকে দেখছি, শুধু তাহলে আর্চটা দেখতে পাচ্ছি, এরকম করে দেখছি, সামনে থেকে নয়। এবার এই জিনিসটাকে উই আর ভিউ ফ্রম দ্য মাউথ। তাহলে মিড লাইনে কে রয়েছে? ফ্রন্টোনেজাল প্রসেস। মিড লাইনে কে রয়েছে? ব্লু কালার ফ্রন্টোনেজাল প্রসেস। অন আইদার সাইড maxillary process, on either side maxillary process, right? Now, and obviously you can easily understand this will give the alveolar arch carrying the tooth. এইখানে টুথ পরে ডেভেলপ করবে, মোলা এইখানে টুথ ডেভেলপ করবে, আর এইখানটা ব্লু কালারের এগেইনস্টে ডেভেলপ করবে টু ইনসিজার টিথ, ওয়ান অন আইদার সাইড, মিডিয়াল ইনসিজার, ল্যাটারাল ইনসিজার, মিডিয়াল ইনসিজার, ল্যাটারাল ইনসিজার। তাহলে এই যে ব্লু কালার ফ্রন্টোনেজাল প্রসেস, or rather more specific, median nasal process will bear these 4 incisor teeth, and rest of the teeth will develop in the maxillary process. That's when in the maxilla, right? Hello? And already I've told you, it gives a plate horizontally, triangular plate. A frontonasal process gives a horizontal triangular plate, and we call it premaxilla. এই প্লেটটা আমরা ভেতরের দিকে যাচ্ছে, এইখানে ইউভিলা রয়েছে, টাং রয়েছে, এইটাকে আমরা বলি প্রিম্যাক্সিলা। আর এটা হচ্ছে ম্যাক্সিলারি প্রসেস, এটা হচ্ছে ম্যাক্সিলারি প্রসেস। এইখান থেকে it gives laterally 2 plates are gives. This laterally 2 plates are gives, which are going towards the midline from the right and left side. We call lateral palatal plate, the lateral palatal process from the maxillary process. And ultimately they are joined together. They are all joined together, and ultimately they are joined together to complete the palate. Initially the palate is fibrous tissue, but later in the anterior two-third region, the osteoblast cell appear, and ultimately it convert it into a bone, the hard palate. And the posterior one-third become soft and containing muscles, and become the soft palate. So these are the, in general, the development of palate. So one triangular plate from the front side, from the frontonasal process, and 2 type, and 2 horizontal plate from the maxillary process. Ultimately, they join together in a Y-shaped manner, and after that, the anterior two-third become ossified, all ossified, and become the hard palate, and posterior one-third become unossified, containing muscles, aponeurosis, etc., become the soft palate. This is the normal, all. But in some bad luck features, this joining is imperfect. Sometimes they joined all other except in the extreme posterior part. Only uvula is affected. Uvula become bifid. আমরা জানি একদম সব প্যালেটের posterior part হচ্ছে uvula. এই ইউভুলাটা হচ্ছে বাইফিড হয়ে গেল, নর্মাল এরকম বাইফিড, মানে একদম পেছনের দিকটা জড়ো হয়নি, খারাপ নয়, ঠিক আছে। কিন্তু আলটিমেটলি বিকজ দ্য জয়েনিং টেক্স ফ্রেম পস্টেরিয়র টু অ্যান্টেরিয়র, আরো ব্যাড লাক যদি থাকে, heart palate, posterior part of the heart palate doesn't join with left side and left side, হতে পারে partial cleft palate। ডেঞ্জারটা কি? The palate, mainly the heart palate, separates the nasal cavity and the oral cavity. So if there is a defect, nasal cavity is continuous with the oral cavity. Food may go up to the nose, nasal cavity. And also the voice will be affected because many of our letters are uttered by touching the palate, by tongue touching the palate, palatal words. So this will be defected. Plus, as there is a continuous with the hard and soft palate, there will be nasal intonation, naki shure of the voice. Aro dangerous, complete hard palate, incomplete hard palate, sorry. Aro dangerous, one side এইখানটা জয়েন করলো না, এই দিকটা জয়েন করে গেছে, one-sided complete cleft palate, দুটো সাইডেই জয়েন করলো না, totally premaxilla triangular process is totally separated from the rest of the palate, bilateral complete cleft palate। আগের গুলি ছিল পার্শিয়াল আর এইগুলি হচ্ছে কমপ্লিট। যখনই প্রিম্যাক্সিলা ইনভলভ হয়ে যাবে তখন আমরা বলবো কমপ্লিট, মেবি ইউনিল্যাটারাল, মেবি বাইল্যাটারাল, ডেঞ্জারাস সিচুয়েশন। অ্যান্ড usually they are associated with the cleft lip also because the lip is also developed from this lower part of the frontonasal process. So they are associated with the cleft lip also. So this is very common. You have seen cleft lip and cleft palate, and cleft palate should be operated. আগে বলা হতো 2 বছর, এখন বলছি no, within 1 year, better within 1 year, যখন the baby is well grown so that he or she can tolerate the surgical stress, the cleft palate should be operated. And otherwise permanent dentation, the dentation defect, দাঁত ভালো করে উঠবে না, প্লাস the voice modulation ও ঠিক হবে না। সুতরাং cleft palate should be examined properly, diagnosed, and treatment, surgical treatment is required. Plus, another danger is that as the oral cavity and food nasal cavity is continuous, the food can go to the nasal cavity, through the nose, through the nasopharynx, it can go to the larynx. So there must be chance of choking. Choke করে যেতে পারে, বিষম খেয়ে যাবে, and also the food may go to the lungs. সুতরাং proper feeding care should be taken. So this is the cleft palate, this is the normal, this is the partial cleft palate. So this is the different modes of cleft palate. This is the bifidibula, partial cleft palate, more or less partial complete cleft palate, unilateral complete cleft palate, bilateral complete cleft palate. পাল্টে দাও, তাহলে আবার ডিটেলসে তোমাদের যখন ডেভেলপমেন্ট হবে তখন হবে, পাল্টে দাও, একই ব্যাপার, ছেড়ে দাও। This is the actual scenario. Look, the cleft palate is also associated with the cleft lip also. The lip টাও ভাগ হয়ে গেছে। এই জায়গাটা ডেভেলপ করছে মিডিয়াল নেজাল প্রসেস, আর এই জায়গাটা ডেভেলপ করে ল্যাটারাল নেজাল প্রসেস থেকে। এই জায়গাটা ডেভেলপ করছে ম্যাক্সিলারি প্রসেস থেকে, আর এইটা ডেভেলপ করছে ম্যান্ডিবুলার প্রসেস থেকে। ওরাল ক্যাভিটি, নেজাল ক্যাভিটি। এইখানে দেখো ওরাল ক্যাভিটি ইজ কন্টিনিউয়াস উইথ দ্য নেজাল ক্যাভিটি। এরপরে যাচ্ছি প্যালেটাল প্যারালিসিস। প্যালেটাল প্যারালিসিস অলরেডি ইউ নো, palate is supplied by the cranial accessory nerve. Cranial accessory nerve is the 11th cranial nerve which carries the information of motor supply to the palate. But cranial accessory nerve, a very small nerve, it cannot by its own supply the palate, because cranial accessory nerve is very small nerve, just coming out from the brain and joined to the spinal accessory, and mainly it passing through the spinal accessory. Then how it will supply the palate? Because from the cranial accessory, 11th cranial nerve, there is no direct supply to the palate. Then how they will supply? আমি বলছি যে cranial accessory nerve supply করছে, but there is no direct supply. How it is possible then? Yes, it is possible because cranial accessory nerve, it gives a branch to join a plexus around the pharynx, on the wall of the pharynx. We call it pharyngeal plexus. In the pharyngeal plexus also there is a supply, there is a vagus nerve. The 10th cranial nerve also gives a branch with the 11th cranial nerve to form a plexus. Also the 9th cranial nerve and also the sympathetic nerve all gives a join together with one another to form a plexus. So cranial nerve gives a contribution to the pharyngeal plexus, and from the pharyngeal plexus, its contribution now carried by the vagus nerve to supply the palate, internal laryngeal nerve and other nerve. So through this vagus nerve, it will supply the palate. Now, if there is a damage of the vagus or cranial accessory nerve, what's happened? The palatal muscle, except tensor veli palatini, will be paralyzed. As a result, levator veli palatini, palatopharyngeal, all muscles, palatopharyngeal, palatoglossal will be paralyzed. So, palate will not move. What is the danger? What is the main function of the palate? Last class I have told you, to close the nasopharyngeal or pharyngeal isthmus. From the nasopharynx to the oropharynx, the passavans ridge come forward and levator veli palatini move the palate up, and passavans ridge come forward so that it closes. So if there is a muscle is paralyzed, levator veli palatini will be paralyzed, palatopharyngeus will be paralyzed, this nasopharyngeal isthmus cannot be closed. So that when we eat food, food may go to the nasopharynx, and from the nasopharynx it may go to the mouth, so that food will come through the nose. Nasal regurgitation of food. Plus, there will be a nasal intonation, because palatal, soft palate movement is necessary for voice modulation. So nasal intonation and nasal regurgitation of food occur if there is a nuclear damage of the vagus or cranial accessory nerve. How do you know in the bedside? Ask the patient. এখান থেকে আ করতে বলবো, এবং ask the patient to say ah. Whenever there is an ah, the musculus uvula symmetrically move up, একদম সুন্দর midline এ move হবে. If there is normal, if there is a defect in the right side of the nerve, then when this patient will speak ah, the uvula will speak to the left side, in the opposite side, unaffected side, by which if the musculus uvula go to the left side, we can know the right-sided paralysis of the muscle supplied the palate. So these are the two clinical anatomy of the palate. So I have told you, in theory, enumerate the muscles of palate, origin insertion of the palate, and the cleft palate is very important for theory. At least one question you must prepare from the palate. Next, পাল্টে এই larynx পুরোটা back. উপরেরটা একদম। So today now we start from palate, we go to the larynx. It's a very important. Tomorrow a B batch possibly I have seen so very beautiful specimen is there like that, and possibly many of them can understand, have understood the larynx. And one batch will be shown today. Very beautiful specimen. What I have shown you in the last class. Very beautiful specimen. All the features of the larynx are there in this specimen. And again, there will be another sagittal section in the last, and you will be learned also. So larynx or voice box, some say, but it is not only voice modulation. It also very important, the gateway of the air entry to the lungs. It acts as a gate, exit valve or entry valve. Not only that, it last part of checking of the inhalation of the foreign particles to the lungs, means to the trachea. একবার larynx cross করে গেলে আর কিছু করার নেই, ও একদম লাংসে চলে যাবে। So it is the larynx. Larynx is a musculo-cartilaginous fibrous structure. It has got a inlet, laryngeal inlet, and lower down it is continuous with the trachea. Larynx is made up of a cartilages, muscles, ligaments, nerves, vessels, etc. Next. So this is the point where the larynx is situated. Here is the hyoid bone. Just below the hyoid bone, you feel the thyroid cartilage, and this is the larynx. But thyroid cartilage is not the beginning of the larynx. Larynx is started high up from the epiglottis. Next. So this is the larynx. Next. Oh, sorry, this is the larynx. Here is our next. Next. Now, this is the frontal view of the larynx. I have already told you, larynx has got made up of a cartilage, muscles, nerves, vessels, and ligaments. In examination, what are the usual questions? Usual questions are many. Theory. I am telling about the theory. Commonly, question is that enumerate the cartilages of the larynx and their histological structure. Next question, enumerate the intrinsic muscles of the larynx with their nerve supply and their action on the rima glottis. Number 3 question, very, very important. If there is an unilateral damage to the recurrent laryngeal nerve, what is the effect in the vocal cord? Movements of the vocal cord. And what happens if there is a bilateral damage? So there are so many questions may come in the larynx. The larynx before appearing in the examination, at least for the and also larynx is important in the OSPE. I have already told you. Usually OSPE question may come median glossoepiglottic fold, lateral glossoepiglottic fold, ediepiglottic fold. A pin will be given and what is its structure, what is its content, such and such. There are so many questions may come in the larynx. So we have to learn the larynx in full. So going back to the larynx, some theoretical discussion. Next. So larynx is made up of a cartilage. These cartilages are, some are paired, some are unpaired. Paired মানে কি দুটো করে আছে, and some are unpaired. Unpaired cartilages are epiglottis. Unpaired cartilages are epiglottis, thyroid cartilage, and very important cricoid cartilage. Our paired cartilages are arytenoid, corniculate, and cuneiform. All are two in number. আর এগুলি একটা। All this histologically, all the cartilage, thyroid cartilage, cricoid cartilage, and main part of the arytenoid cartilage are hyaline in nature, except the other cartilages are elastic. কি কি ইলাস্টিক কার্টিলেজ রয়েছে? এপিগ্লটিস, corniculate, and cuneiform, and also the tip and vocal process of the arytenoid cartilage. So arytenoid cartilage is a mixed, histologically mixed. Arytenoid cartilage is like that. Arytenoid cartilage is like that. It has got a base, apex, some surfaces, and two processes, vocal process and a muscular process. Except the tips and the vocal process, all these are hyaline cartilage. But tips and vocal process are elastic cartilage. So epiglottis is elastic cartilage, corniculate is elastic cartilage, cuneiform is elastic cartilage, and tips and vocal process of the arytenoid cartilage are elastic cartilage. Thyroid is a hyaline cartilage, cricoid is a hyaline cartilage, and main part of the arytenoid is the hyaline in nature. The hyaline cartilage ossify after 25 to 30 years. 40 to 45 years, the hyaline cartilage will ossify. But elastic cartilage never ossify. And it is essential because the vocal cord, the movement of our voice is attached in the tips of the vocal process. So it is elastic because if it is ossified, the movement of the vocal cord will be hampered. So nature made it, the vocal process, the elastic cartilage, because the main vocal cord, the movement of, so that our phonation and also the respiratory movements, air entry and air exit occurs through this vocal movement of the vocal process, a vocal fold, sorry. And this vocal ligament, a constituent of the vocal fold, is attached to the tips of the vocal process. I will come later on. So these are the cartilages. There are ligaments, there are muscles. I will come later on. Next. This is the inside of the larynx, cut section of the thyroid cartilage, cut section of the epiglottis. Look, epiglottis starts from a lower part is in the middle of the thyroid cartilage and upper part is above the hyoid bone. So that you can see the tip of the epiglottis through your mouth. So, the epiglottis is situated in this fashion. The lower part is more or less in the middle part of the posterior surface of the thyroid cartilage and upper part is just above the base of the tongue. So, this is the cut section of the epiglottis and cavities look like that. This is the cut section of the thyroid cartilage. This is the cut section of the cricoid cartilage and this is the arytenoid cartilage. So, arytenoid cartilage you cannot see from the front. Arytenoid cartilage you can only see from the back side. And above the arytenoid cartilage, this is the corniculate and here the cuneiform cartilages. Next. Okay, next. এখন থাক। Usually the dimension adult male cartilages, the vertical diameter is in adult male 44, the transverse diameter is 43 and anteroposterior diameter is 26 millimeter. In female, diameter is far less, 43, 26 and 20 millimeter. So the thyroid cartilage is much larger in case of a male than in female. And internal diameter, এটা খুব ভালো করে শোনো, internal diameter of the larynx, internal, ভেতরের দিকে, internal diameter of the larynx, ভেতরের দিকে যদি larynx এর diameter মাপি, at birth it is 3 millimeter. First year 3 millimeter, second year 3 millimeter, third year 3 millimeter. That's when birth to 3 years, the internal diameter is 3 millimeter. After that, every year it grows by 1 millimeter. So at 4th year, 4 millimeter, 5th year, 5 millimeter, 6th year, 6 millimeter, up to 12th year. 12th year, it is 12 millimeter. And after that, no such increase. So in adult and 12-year child has got same value. That is the 12 millimeter. Why it is important? Because the endotracheal tube. We have to insert in every surgical and general anesthesia the endotracheal tube so that the oxygen and anesthetic gas tubes are given. And also endotracheal tube is a life-saving tube where the tube is inserted into the larynx. Through the larynx to the trachea. Through the mouth, a tube is inserted through the larynx to the trachea to give oxygen and other gases, anesthetic gas, so that the patient become unconscious. Plus, it is an important procedure to move out the foreign body and other procedure can be given. So, endotracheal tube diameter is very important. At an adult diameter, একটা 4 বছরের বাচ্চাকে ঢুকিয়ে দিতে পারি না. We cannot insert a large endotracheal tube into a child. So, what is the ideal diameter of a 5th-year child? 5. What is the ideal diameter of a 6th-year child? 6. What is the ideal diameter of a 12-year child? It's the adult. Whenever the child is a 12th year, you ask the sister, give me the adult endotracheal tube. You can insert it. So, internal diameter of larynx is more important than this in 44, 43, 33. It is just anatomical view, otherwise not such important. Next question is that, what is the voice quality? The length of the vocal cord, the thyroid gland, thyroid cartilage has got a 2 plates, one on either side. This is the right, this is the left. This is called the thyroid lamina. It is called the lamina of the thyroid cartilage. This is the lamina, the left lamina, and this is the right lamina. The two lamina anteriorly is make an angle, and this is known as the thyroid angle. And in the posterior part of the thyroid lamina, here the anterior end of the vocal cord is attached. আসবো আমি পরে। এটা তোমরা কি দেখছো? anterior surface, আমার anterior surface of the thyroid lamina. যদি এরম ভাবে দেখাই তাহলে এটা হচ্ছে posterior surface of the thyroid lamina. এইখানে দুপাশে দুটো vocal cord এখানে অ্যাটাচ হয়ে রয়েছে। সুতরাং এই অ্যাঙ্গেলের উপরে length of the vocal cord, tension of the vocal cord depends. In adult male, this angle where the two lamina and this joint is called the thyroid angle. So this is the thyroid angle. Here the right lamina and left lamina makes an angle. It is 90 degree in case of adult male. And female it is 120 degree. And as number one. Number two, I have already told you, gradually from the birth, the thyroid cartilage and other cartilage gradually increases. And after puberty, after 12th year, 14th year, there is a huge enlargement of the thyroid cartilages in male, but not in female. Female becomes childlike even after puberty. The length of the female cartilages are not increased so much. So that voice quality of the female and child is more or less same. যত length কম হবে, the voice will be high pitched. So the female voice is high pitched as the child voice. আর যত length বাড়বে, the voice will be low pitched, so the volume will be so it is the male voice. So these are some of the physiological aspects of the larynx. Now going to the anatomical aspect. The thyroid cartilage. I have already told you, thyroid cartilage has got two lamina joined together by a angle, thyroid angle, which is very prominent in case of a male. We call thyroid eminence or Adam's apple. And these lamina has got a superior border and an inferior border. It has got a superior border and an inferior border. And from the posterior side, there are two horns. Shingher moto ache, superior horn and an inferior horn. Upper border of the thyroid cartilage, a membrane is attached. To the hyoid bone. কালকের ব্যাচে পড়িয়েছি বলো, to the lower border or the upper border of the hyoid bone. Upper border. এই জিনিসটা পরীক্ষায় আমরা জিজ্ঞেস করি, যদিও এর কোনো মানে নেই, কিন্তু সবাই ভুল করে। আমাদের ধারণা কি হয়, এই thyroid, it is a membrane. It is attached to the upper border of the thyroid cartilage and to the lower border of the hyoid bone. No. It passes deep to the hyoid bone to be attached to the upper border of the hyoid bone. যদি আমরা সাইড ভিউ দেখি এই রকম, এটা যদি থাইরয়েড কার্টিলেজ হয়, এটা যদি হায়োয়েড বোন হয়, it is attached in this fashion and separated by a bursa known as the subhyoid bursa. So it is attached to the upper border of the hyoid bone. And this thyroid, it is known as the thyrohyoid membrane. It is pierced by, often asked, by one nerve and one vessel. One nerve and a vessel, internal laryngeal nerve, a branch of the superior laryngeal nerve, and a superior laryngeal artery, a branch of the superior thyroid artery, one on either side, edike edike. So thyrohyoid membrane is pierced by internal laryngeal nerve, which is a branch of the superior laryngeal nerve, which is a branch of the vagus nerve, 10th cranial nerve, and internal laryngeal artery, which is a branch of the superior laryngeal artery, which is a branch of the superior thyroid artery, through by which the internal laryngeal nerve, by piercing this thyroid membrane, entered the inside of the larynx. Gelo. Next, the lower border. Lower border of the thyroid cartilage, there are one ligament, এটা ভালো করে লক্ষ্য রাখো, and one muscle is attached. Very important muscle. These are known as the cricothyroid muscle, tensor of the vocal cord. Cricothyroid muscle. It takes origin from the outer lip of the upper border of the cricoid cartilage. This is the cricoid cartilage. This is the cricoid cartilage. This is the thyroid cartilage. From the lower upper border of the cricoid cartilage, arch of the cricoid cartilage, a muscle arises and they become attached to the lower border and the inferior horn of the thyroid cartilage, and this is known as the cricothyroid muscle. Only intrinsic muscle which can be seen from the outside. Important. Why? There are two groups of muscles of the larynx. One is called extrinsic muscle, which moves the larynx up and down, which can be seen from the outside of the larynx. Extrinsic muscle, mylohyoid muscle, thyrohyoid muscle, sternothyroid muscle, all have you seen in the triangles of the neck. They move the larynx up and down, and they can be seen from outside. আমরা dissection করলেই দেখতে পাচ্ছি larynx কাটতে হচ্ছে না. We have to not incise the thyroid cartilage or rather to open the larynx and see the muscle. We can see from outside, and these are called the extrinsic muscle of the larynx. So, and there are other important muscle known as the intrinsic muscle. All the intrinsic muscles usually can be viewed after you cut the laryngeal cartilages, especially the thyroid cartilage. কাটলেই তবে দেখতে পাবো বা পেছন থেকে দেখতে পাবো, because they remain within the cavity inside of the larynx. But only intrinsic muscle, though it is an intrinsic muscle, which can view it from the outside. It is the cricothyroid muscle. Key muscle? Cricothyroid muscle. Cricothyroid muscle, very important. বারবার বলছি. Next, in the middle and lower part in midline, there is a strong ligament known as the median cricothyroid ligament. Median cricothyroid ligament or conus elasticus. Conus elasticus, midline. It has side view দেখছো, midline. And raised part of the lower border, in the inside lower part, another membrane-like ligament is attached. We call it lateral cricothyroid ligament or cricovocal membrane. Or cricovocal membrane. তাহলে আমরা থাইরয়েড কার্টিলেজের আমি মাসলটাকে আঁকছি না। এই মিড লাইনে দেয়ার ইজ অ্যান লিগামেন্ট। median cricothyroid ligament, and lower part এটা হচ্ছে cricoid cartilage, lower part আরেকটা ligament, membrane like ligament, we call it lateral cricothyroid ligament. এটা হচ্ছে median cricothyroid ligament. এটা হচ্ছে ল্যাটারাল। এই জিনিসটা ভুলবে না কিন্তু, ল্যাটারাল ক্রিকোথাইরয়েড লিগামেন্ট এর আরেকটা নাম হচ্ছে ক্রিকোভোকাল মেমব্রেন। এটা হচ্ছে খুব স্ট্রং, খুব থিকেন, and it is very fine like a paper, পাতলা শীটের মতো। তো এটার নামটা কি? ল্যাটারাল ক্রিকো অ্যান্ড ক্রিকোভোকাল মেমব্রেন। অনেকে মিডিয়াল ক্রিকোথাইরয়েড লিগামেন্টকে বলে কোনাস ইলাস্টিকাস, অনেক বইতে দুটোকেই বলছে কোনাস ইলাস্টিকাস। তবে আমি মনে করি এইটাকে কোনাস ইলাস্টিকাস বলা ভালো এবং এইটাকে ল্যাটারাল ক্রিকোথাইরয়েড লিগামেন্ট অর ক্রিকোভোকাল মেমব্রেন। সো ক্রিকোভোকাল মেমব্রেন ইজ অ্যাটাচড টু দ্য লোয়ার বর্ডার অফ দ্য থাইরয়েড কার্টিলেজ, জাস্ট আপ, ঠিক লোয়ার বর্ডারে লাগে না, ওপরে আরেকটু উঠে যায়। এটা লোয়ার বর্ডারে লাগে না, এটা আরেকটু ওপরে উঠে যাবে। আরেকটু বলে নিচ্ছে এখানে, এটা লোয়ার বর্ডারে লাগছে না, এটা আরেকটু ওপরে উঠে যাচ্ছে। ইনসাইড অফ দ্য larynx and upper part is thickened. Upper part of the cricovocal membrane is thickened and also the median cricothyroid ligament is thickened. Upper part is thickened and it is from the vocal cord. So vocal cord is nothing but the upper thickened part of the cricovocal membrane. এটা আমরা কি থাইরয়েড, এটা আমরা কিন্তু দেখতে পাচ্ছি না, এটা থাইরয়েড ল্যামিনা দিয়ে ঢাকা আছে, এটা ভেতর দিয়ে ঢুকে যাচ্ছে। তোমরা যখন স্পেসিমেন দেখবে বুঝতে পারবে। তাহলে আমরা এটা শিখলাম দুটো জিনিস। এছাড়াও আরেকটা হচ্ছে জয়েন্ট। ইনফিরিয়র হর্ন of the thyroid cartilage makes a synovial joint with the cricoid cartilage, known as the cricothyroid joint. Slight gliding and rotatory movements is possible. This joint is a synovial joint. So it has got a capsule. So it is a করছে। তাহলে আপাতত এটা থাক। নেক্সট আমি চলে যাচ্ছি এপিগ্লটিস। এর নামগুলি দিয়েই কিন্তু স্ট্রাকচার কি টাইপের we can be। থাইরয়েড means shield. থাইরয়েড coming from a Greek word means shield, ঢালের মতো। As the thyroid looks like a shield, so it is called thyroid. Cricoid means ring. Cricoid is totally ring. And epiglottis means leaf, as it is a leaf-like. Epiglottis is very important. It is actually a leaf-like structure. It has got apex, lateral border and a base. যদি ল্যাটারাল ভিউ দেখি, আমরা যদি ল্যাটারাল ভিউ দেখি, if it is a tongue, এটা হচ্ছে টাং যদি হয়, এপিগ্লটিস এরকম, এটা হচ্ছে হাইয়ার্ড বোন, এটা হচ্ছে থাইরয়েড কার্টিলেজ। এই টাঙের ওপরে উঁকি মারছে। দিস ইজ দ্য ল্যাটারাল ভিউ। কেমন? এন্ড তার মানে এইখানে টাং রয়েছে। আজকে এইটুকুনি পড়িয়ে ছাড়ছি, এটা টাং রয়েছে, এটা হচ্ছে টাং সামনে, এটা হচ্ছে অ্যান্টেরিয়র সাইড। The epiglottis, the anterior surface of the epiglottis in the midline, it is attached to the tongue by a ligament known as the median glossoepiglottic ligament or median glossoepiglottic fold. Midline is single, একটাই। Midline এ the anterior surface of the epiglottis, এটা anterior surface. Anterior surface মানে সামনের দিক, সামনে টাং রয়েছে। In midline it is attached to the base of, আর টাঙের posterior থার্ডটাকে বলে base of the tongue. Is attached to the base of the tongue by a fold of ligamentous fold we call median glossoepiglottic fold, because glosso means tongue. And laterally, one on either side, it is attached by a lateral glossoepiglottic fold. Lateral glossoepiglottic fold. Lateral glossoepiglottic fold. And there is a depression between the median and lateral, and this depressed part is called vallecula of the tongue. কালকে দেখিয়েছি vallecula of the tongue, where there is an lodgement of the chance of lodgement of the foreign body, especially the fish bone. So this is extreme posterior part. is known as the vallecula of the tongue, which is the taste sensation of the vallecula of the tongue is carried by the vagus nerve. Other taste sensation carried by the chorda tympani and the glossopharyngeal nerve. But এইখানে কিন্তু taste sensation is carried by the internal laryngeal nerve of the vagus because it is developmentally different. So this is the vallecula of the tongue. Anteriorly, and base of the tongue, epiglottis, is attached to the posterior surface of the thyroid cartilage by a ligament. Now, thyroepiglottic ligament. Is a thyroepiglottic ligament. আজকে এটা থাক, কালকে এই নেক্সট ক্লাসে আমরা বাকিটা করব। তার আগে তোমরা দেখে নেবে, so you have got idea.